149th weekly session. We are on CMAAO platform, an association of about many countries, medical associations. Today we are talking about stroke in children. We have seen a lot of new age problems going on in children. And today we have Dr. Bharat Parmar, who is a professor and a head of pediatrics department in Zydus Medical College in Gujarat. And I welcome him to give us immense knowledge about what is going on in the children and why are these strokes happening, and to enlighten us how we can overcome it. Over to you, Dr. Bharat.
Okay, good morning to all. First of all, thank you for giving me opportunity to highlight my views on a stroke in children. Zibal, hello.
Yes, sir. You are audible, sir.
Dr. Bharat, you may share your screen.
Yes, sir.
So you need to click share screen and then go to the presentation and click that. So meanwhile, till the time Dr. Bharat shares the screen, Dr. Naidu, do you have anything to share about Malaysia in terms of the what's going on in terms of the medical side of it?
You mean in terms of what, Saurabh? Sorry.
General, like I think the COVID is over everywhere now.
Yes, yes. But we had a problem with the flu, the influenza A.
Okay.
That had come in, and then now that is settling down. Of course, dengue is prevalent.
Dr. Saurabh, I have one suggestion.
Yes.
Can every speaker send the presentation to you before, because sometimes the presenter.
No, he just did that.
Have you seen? Hello.
Okay, can you open the presentation? I can see. Can you maximize the presentation?
Maximize.
Yeah, just click that. Okay, I have asked for a remote control. Can you give me okay? Okay. I'll do it for you. It's okay. Okay, you can go and give the presentation. I'll handle you. You don't have to touch your laptop anymore. I will do that.
Okay. Stroke is an.
So we have Dr. Bharat Parmar, and we'll start the presentation. I've already introduced him, and so over to you.
Okay. Pediatric.
Yes.
Pediatric stroke is an acute cerebrovascular event.
Sir, go on slide mode, sir. Can you go down on a?
No, this is, I think, it's a different version altogether. I don't see any slide mode, but I think we will continue with this mode. It's okay. I don't see any slide mode over here. I don't know why, but he must be using a different software. Or maybe, wait, let me see.
Yes.
Layout, okay. Layout.
Go down, okay.
No, this is a different layout.
This one is okay.
This is okay. This is okay. Let's continue. Okay. Yeah. Please go ahead.
Pediatric stroke.
Oh, sorry.
Pediatric stroke is an acute cerebrovascular event that occurs in children after 28 days of life up to 18 years of age. Pediatric stroke, it results in a significant morbidity and mortality. Ischemic stroke can be due to arterial ischemia or a venous sinus thrombosis. Hemorrhagic stroke is either due to non-traumatic intraparenchymal hemorrhage or a subarachnoid hemorrhage. In young children, the symptoms could be non-specific. Stroke-like conditions are very common. Hence, neuroimaging is mandatory for all cases of suspected stroke in children. Clinical awareness and the recognition is crucial for diagnosis to ensure prompt management for a better outcome. Childhood stroke is rare but a serious medical condition affecting children range 29 days of life to the 18 years of age, which is associated with a high morbidity and mortality. The risk factors are multifactorial in pediatric population, different from adults. There remains an insufficient understanding of childhood stroke, hence, in its review, etiology, and clinical features and consensus-based treatment are discussed here. Stroke is defined by World Health Organization as a clinical syndrome consisting of rapidly developing clinical signs of focal, there's a global in case of coma, disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than vascular origin. Stroke occurring from 28 weeks of gestation to the first 28 days postnatal of life is broadly classified as a perinatal stroke, while after 28 days postnatal days to 18 years of age is classified as childhood or a pediatric stroke. Perinatal stroke present either shortly after the birth in early neonatal period with the focal seizures and encephalopathy, and it is termed as acute perinatal stroke and can be delayed presentation with the pathological early hand preference and the focal seizures with the chronic infarct and termed as resumed perinatal stroke. Pediatric ischemic stroke, it affects in an estimated 1 to 2 in 1 lakh children, that's the non-neonates, annually in Western countries. And hemorrhagic stroke make up to about half of the pediatric stroke with an incidence approximately 1 to 1.7 in 1 lakh per year. Childhood stroke types, ischemic stroke versus hemorrhagic stroke, arterial stroke versus venous stroke, and anterior circulation stroke versus posterior circulation stroke. Stroke mimics condition, there is HEMI, there is H hypoglycemia or hyperglycemia, E epilepsy, M multiple sclerosis, there is a metabolic malaise, and migraine hemiplegic, as well as vestibular hemiparesis, and intracranial tumors or infections such as meningitis, encephalitis, and the brain abscess in case of phalanx. Childhood stroke syndrome classifications and types. Conventionally, the stroke could be either ischemic or hemorrhagic. Ischemic stroke could be either due to thrombotic or embolic phenomena. Ischemic stroke can either involve arterial territory or a venous territory. There is a difference in etiological evaluation and also the management of arterial ischemic stroke and cerebral sinus venosus thrombosis. There is a venous stroke. Hence, it is better to use specific terminology in a clinical practice for a better clarity. The term hemorrhagic stroke is used to refer all non-traumatic intracranial hemorrhage in children. There is a subdural hemorrhage or intracerebral hemorrhage. With the exception of neonatal intraventricular hemorrhage, hemorrhagic stroke can be either non-traumatic, there is an intraparenchymal hemorrhage or a subarachnoid hemorrhage. The transient ischemic attack and the stroke-like episodes are not stroke, and this is not included in WHO definition of stroke. Focal neurological deficit is less than 24 hours is termed as transient ischemic attack. Focal neurological deficit caused by direct vascular cause are included under the stroke-like episodes. Difference between stroke and a stroke-like condition. In stroke, there is a deficit, focal neurological deficit, and there is a specific vascular territory. Onset is abrupt, and neurological features like negative neurological symptoms like paresis, aphasia, and visual loss. While in case of stroke-like episodes, focal neurological deficit is rare, onset is gradual, and the neurological feature, there is a positive neurological symptom such as involuntary movement, aura, and hemibelismus. Level of consciousness in stroke, there is a normal or impaired, while and weakness is severe, and triggering or precipitating factor in stroke is uncommon. While in case of stroke-like condition, mostly the level of consciousness, it is impaired. There is a toxic metabolic encephalopathy, and weakness usually mild, and triggering factor in case of stroke-like condition, that is migraine, hypoglycemia, vestibulopathy, and metabolic disorders. In neuroimaging, there's a CT, MRI of brain. In case of stroke-like condition, it corresponds to specific vascular territory. And in case of stroke-like condition on neuroimaging, they do not correspond to the specific vascular territory. In magnetic MRI, there is a vascular obstruction in stroke-like condition, while in case of stroke-like condition on MRI, it is usually normal. Type of stroke resulting in, there is an infantile hemiplegia. So what is the pathomechanism? It is ischemic stroke due to thrombus and emboli. There is a hemorrhagic stroke. Vascular, there is an arterial stroke and the venous stroke. And territorial involvement, there is anterior circulation stroke and posterior circulation stroke. All these leads to, there is an acute infantile hemiplegia. The broad category, which are the risk factor for this acute infantile hemiplegia? First, there is a cardiac. There is a cyanotic congenital heart disease, most common in encephalopathy and TGA, infective endocarditis, cardiac arrhythmias, cardiomyopathy, cardiac catheterization, and paroxysmal emboli through patent foramen ovale. Hematological, there is a severe iron deficiency anemia, sickle cell anemia, thrombocytopenia, polycythemia, paroxysmal nocturnal hemoglobinuria, deficiency of antithrombin 3, protein C, factor V-laden mutation, leukemia, disseminated intravascular coagulation. These are the risk factors for acute infantile hemiplegia. Infection, otitis media, mastocytitis, sinusitis, meningitis, cerebral abscess, encephalitis, retropharyngeal abscess, and post-varicella angiopathy. They are also the precipitating factor for acute infantile hemiplegia. Also due to vasculitis, there is a systemic lupus erythematosus, immune vasculitis, anti-phospholipid antibody syndrome, and mineralizing angiopathy is a risk factor for acute infantile hemiplegia. Pertaining to genetic risk factor, there is a MELAS, Fabry's disease, and homocystinuria also cause acute infantile hemiplegia. Also, certain neurocutaneous syndrome, there is a Sturge-Weber syndrome and Face syndrome, they result into acute infantile hemiplegia. Other uncommon, there is a nephrotic syndrome, severe dehydration, head trauma, neurosurgery, postcranial irradiation, and the drug abuse. Also, they are the precipitating factor for acute infantile hemiplegia. Placental embolism and placental vasculopathy, intrauterine death of twin can be associated with intrauterine or perinatal stroke. These are the precipitating factor for perinatal stroke. Arterial ischemic stroke. An arterial ischemic stroke, AIS, occur due to infarct in a defined arterial territory, either due to the thrombotic or embolic phenomena. It presents with a consistent clinical symptoms and signs depending upon the territory involved. Arterial ischemic stroke is most common mechanism, that is 53 to 85% of the cases. The recent International Pediatric Stroke Study has identified at least one risk factor in 89% cases and presence of two or more risk factors in 47% of ischemic stroke. The IPSS group classified causing there is arterial ischemic stroke into following category: cardiac disease, sickle cell disease related arteriopathy, and arterial dissection. Also in moya arteriopathy and other cause, they lead to arterial ischemic stroke. Greatest recurrence risk among the pediatric stroke is for arterial ischemic stroke. Among them, arteriopathy has the highest risk of recurrence. Childhood arterial ischemic stroke is markedly different from adult in risk factor and presentation. Cerebral arteriopathy, stenotic cerebral arteriopathy, is identified as an arterial ischemic stroke, etiology 60 to 80% of previously healthy child, and course of this arteriopathy is a stronger predictor of recurrent events. Moya arteriopathy and the sickle cell disease related to arteriopathy are most frequent from the chronic intracranial arteriopathy in children. There are increasing reports of mineralizing angiopathy of lenticular stria vessel, and primary angiitis of the CNS is rare in children, resulting to arterial ischemic stroke. Focal cerebral arteriopathy. Focal cerebral arteriopathy, there is a 30 to 40% of the children with arterial ischemic stroke arteriopathy have a unilateral focal cerebral arteriopathy characterized by unique form of arterial insult with unilateral focal stenosis of terminal carotid trifurcation and characteristic monophasic course. Childhood is focal cerebral arteriopathy suspected to be an inflammatory vessel wall pathology triggered by infection, typically varicella infection. Recurrence occur for a great majority in the first 6 months after the index event. Hence, aspirin 5 mg per kg per day is recommended for at least 18 to 24 months, with the further stabilization and the regression of arterial stenosis with the help in preventing future recurrence. Stroke rarely recur when progression of stenosis stops. Arterial ischemic stroke etiology. Cardiac, there is a congenital cyanotic, congenital acyanotic heart disease, cardiomyopathy. Acquired cardiomyopathy, rheumatic heart disease, infective endocarditis, catheterizations, and cardiac arrhythmias. Hematological, iron deficiency anemia, sickle cell anemia, and thrombophilia. There is a prothrombotic state. These are the etiology for arterial ischemic stroke. Next, cervicocephalic arterial dissection. There's a traumatic or non-traumatic suspect vessel wall defect in a tribal trauma. Dissection of internal carotid artery result from blunt trauma to the vessel in a tonsillar fossa, commonly seen with pencil injury. Spontaneous dissection should be suspected in a setting of acute infection. Cerebral arteriopathy, idiopathic focal cerebral arteriopathy, and transient cerebral arteriopathy. post-varicella angiopathy, and vasculitis involving CNS vasculitis, systemic vasculitis, or infective vasculitis result into arterial ischemic stroke. In fibromuscular dysplasia, Moyamoya disease, Moyamoya syndrome, and mineralizing angiopathy of lenticular vessel also result into arterial ischemic stroke. Also, certain genetic cause, there is a metabolic cause, there is a Fabry disease, homocystinuria, and mitochondrial disorders also result into arterial ischemic stroke. Also, some arterial abnormalities like neurofibromatosis type 1, there is a Sturge-Weber syndrome, and the phase syndrome, it result into arterial ischemic stroke. Also, certain condition, there is no cause for this arterial ischemic stroke, there is a idiopathic one. So what is FAST? FAST, there is a face, arm, speech, and the time. So there is a 4 question regarding this arterial ischemic stroke. Has the face dropped? There is a facial weakness. Can they lift both the arm? Is there any trip of one side? There is hemiparesis. Is the speech slurred? So there's a slurred speech. And trying is critical, and timely medical care should be given within 24 to 48 hours. So hemiparesis and the focal deficit, change in the mental status, headache, seizures, and the speech disturbance are a common clinical feature of arterial ischemic stroke. And this FAST, there's a face, arm, speech, time criteria to determine stroke in children and young people, but do not rule out stroke in an absence of FAST signs. The FAST is an acronym useful in screening and recognition of stroke at a community level in a Western guideline. Symptoms indicative of stroke where neuroimaging is indicated. New onset of focal seizures, new onset of severe headache, altered mental status including transient loss of consciousness or behavioral changes, new onset of ataxia, vertigo, and dizziness, sudden onset of neck pain or neck stiffness, and witness acute focal neurological deficit, which has since resolved. So these are the indications of neuroimaging. Clinical features, difference between anterior and posterior circulation stroke based on a specific territory. In anterior circulation stroke, involve middle cerebral territory, and stroke is most common. In middle cerebral, there is an anterior cerebral artery territory and middle cerebral artery territory. Clinical features are hemiparesis, aphasia, visual field defect, altered mental status, seizures, aphasia, apraxia, amnesia suggest cortical involvement. While in case of posterior circulation stroke, mostly involve posterior cerebral artery territory. There is a vertebro-basilar system and brainstem stroke syndrome. There is a posterior cerebral artery territory, and the clinical features ataxia, vertigo, diplopia, and vomiting. Next, in case of middle cerebral, anterior and middle cerebral territory, the weakness of the lower limb, there is a contralateral hemiplegia with or without loss of voluntary control micturition with contralateral hemianesthesia and contralateral homogeneous hemianapsia, aphasia. And in case of this anterior and middle cerebral stroke, the behavioral and memory disturbance is also not there. While in case of posterior cerebral territory, this arterial stroke, the clinical features, there is a sensory loss, pain in movement disorders due to thalamic involvement, and visual field loss such as seminospia and quadroanopia. And also there is result into cortical blindness due to posterior cerebral stroke. Brainstem stroke included under the posterior circulation stroke. There are three types: affection of midbrain, affection of pons, and affection of medulla. The affection of the midbrain in a Weber syndrome, and it characterized by third cranial palsy with contralateral hemiplegia. While if there's an involvement of the pons, there is a Fovili syndrome and presented as sixth and seventh nerve palsy with a contralateral hemiplegia. If there is an involvement of medulla, there is a Wallenberg syndrome. It leads to ipsilateral cerebral sign with sensory loss over face and bulbar muscle weakness, nystagmus and vertigo due to inferior vestibular nucleus, and Horner syndrome, contralateral loss of pain and the temperature over the torso and the limb. If there is an involvement of the midbrain, there is a Benedict syndrome characterized by third cranial palsy, contralateral hemiplegia with tremor, rigidity, and ataxia on the opposite side. If involvement of the pons, there is a Millard-Gubler syndrome characterized by seventh cranial palsy with contralateral hemiplegia. But if involvement of the medulla, there is a Desjardins syndrome characterized by ipsilateral 12th cranial palsy, contralateral hemiplegia with contralateral loss of posterior column sensation. If there is a midbrain involvement, there is a Perinaut syndrome characterized by upward gaze palsy, pupillary light near dissociation, and convergence retraction nystagmus and lid retraction present in Perinaut syndrome due to affection of midbrain. Investigation in arterial ischemic stroke. There is a first you should do CT brain and CT angiography, MRI brain with MRA or MRV, complete blood count, peripheral smear, sickling test, ESR and the blood sugar, liver function test, renal function test, urine routine micro if needed, screen for infection. There's a retroviral serology, enteroviral study, mycoplasma and varicella zoster virus titer, coagulation profile, there's a PT and APTT, and cardiac evaluation including ECG with prolonged lead to recording and echocardiography. This is first tier investigation in arterial ischemic stroke. In second tier investigation to be done within first week, there is a lipid profile, serum lactate, transcranial or carotid Doppler, prothrombotic workup, that is serum homocysteine and factor V-laden mutation, methyl tetrahydrofolate reductase and gene mutation, prothrombin gene mutation and lupus anticoagulant, APLA antibodies, prothrombotic workup test which are to be done after 3 months. There is a protein C, protein S, antithrombin 3, and activated protein C resistance. In third tier investigation performed on an individual basis. Metabolic workup, there is a ABG, serum lactate, serum ammonia, TMS, and urinary GCMS. Vasculitis workup, there is a digital subtraction angiography, mitochondrial disorders workup, CSF lactate and pyruvate, and muscle biopsy and genetic study, leptomyelial and the brain biopsy in case of suspected small vessel primary CNS vasculitis. Neuroimaging is mandatory in all cases in whom stroke is suspected. MRI brain is an investigation of choice in pediatric stroke. However, it is recommended that at least CT brain with CTA is performed within an hour of arrival at hospital. CTA is limited to intracranial part if there is evidence of intracranial hemorrhage or from vertex to neck if the CT brain does not show hemorrhage. CT brain, it is initial imaging if hemorrhagic stroke is suspected, and CT brain may be normal in first 12 hours in ischemic stroke. More than 50% of CT brain done at the time of presentation of child with stroke is normal. So CT brain is a good choice for pediatric stroke in an acute care setting where MRI brain facility is not available. It is also helpful in identifying mineralizing angiopathy of lenticulostrial artery malas by detecting calcification. MRI should be done for a suspected case of stroke at the time undertaking MRI. This should cover the aortic arch to vertex in arterial ischemic stroke and can be limited to the intracranial circulation in hemorrhagic stroke. Digital subtraction angiography (DSA) is an ideal investigation of choice which helps in a detection of vasculitis, collateral blood flow, emboli within blood vessel, and aneurysmal anatomy. It is useful investigation of choice in Moyamoya disease where puff of smoke appearance is made out on digital subtraction angiography. Also consider DSA in any child where etiology of stroke has not been made out. Treatment in case of stroke. There is an acute treatment and the long-term treatment. In acute phase, there is a supportive care, stabilize airway, breathing, and circulation. Temperature and oxygenation should be maintained normally along with avoidance of hypoglycemia and hyperglycemia. In acute setting, the relative hypertension is not rare, but must not be aggressively lowered except in the following circumstances. That is, in children who are otherwise eligible for intravenous thrombolysis, but in whom systolic blood pressure exceeding 95th percentile for the age by more than 15%. And second indication, there is hypertensive encephalopathy in presence of end organ damage or dysfunction. There is a cardiac failure and renal failure. They are indication of anti-hypertensive therapy. In case of stroke, with feature of raised intracranial pressure, measure to reduce cerebral edema is required to ensure adequate cerebral perfusion, pressure, and swallowing should be assessed concurrently with the sensorium to decide about mode of nutritional support. There is an enteral, oral, tube feeding, or parenteral. Next. After stabilization, physiotherapy and rehabilitation should be planned. Early mobilization is needed to decrease the risk of aspiration pneumonia, pressure sores, deep vein thrombosis, and contractures. Next. In supportive care, there is an antiplatelet therapy like aspirin, anticoagulant therapy like heparin, low molecular weight heparin, recanalization therapy, there is acute thrombolytic therapy and mechanical thrombectomy. And the long-term treatment in case of AIS, there is a neuro-rehabilitation and seizure control in case of epilepsy. And secondary prevention for these AIS, there's an antiplatelet drug, aspirin, clopidogrel, dipyridamole, anticoagulant therapy, low molecular weight dextran, and warfarin for secondary prevention of AIS. Specific treatment of underlying cause of AIS. Evidence regarding supportive therapy after stroke in children. There is a first recommendation. There is a supportive measures for AIS should include control of fever, maintenance of normal oxygenation, control of systemic hypertension, and normalization of serum glucose level. In class 2 recommendation, treat dehydration and anemia in children with stroke. There is a severe iron deficiency anemia and sickle cell anemia. Next. And class 3 recommendation, there is no evidence that use of supplemental oxygen is beneficial in children with stroke in absence of hypoxemia. In absence of clinical and electrographic seizure, prophylactic administration of anti-epileptic medication in children with ischemic stroke is not necessary. In absence of additional data confirming its safety and efficacy, hypothermia should not be used in children with stroke except in the context of clinical trial. Next. Class 3 recommendation, there is evidence regarding thrombolytic therapy for childhood stroke. Until there are additional published safety and efficacy, there is TPA is not recommended for AIS outside of clinical trial. So remember, however, there is a class 3 recommendation considering thrombolytic therapy, that is TPA, tissue plasminogen activator, in selected children with venous stroke due to CVST. There is more supportive evidence for intravenous thrombolysis in venous ischemic stroke than arterial ischemic stroke in children. In class 1, that individual with also in Fabry disease should be receive alpha galactosides and the replacement therapy. And in class 2 recommendation that to seek and treat iron deficiency because it may increase risk of AIS in conjunction with other risk factor. Measure the serum homocysteine level of children with CVST. There's a cerebral venous thrombosis and AIS, and institute measure to lower the homocysteine level when it is higher than normal. Diet and supplementation of folate, vitamin B6 and vitamin B12. This is all about pediatric stroke treatment. Hemorrhagic stroke. Approximately 50% of the childhood stroke are hemorrhagic origin. In contrast, approximately 50% in adult stroke. Hemorrhagic stroke are two types. There's intraparenchymal hemorrhage or a subarachnoid hemorrhage. The major cause of hemorrhagic stroke is a vascular malformation, which include arteriovenous malformation, aneurysm, cavernomas. Hence, look for any hemangiomas or vascular or neurocutaneous marker on a general examination. And drug-induced, there is a phenylpropylamine, there is a nasal decongestant, cocaine, and other illicit drug, they cause hemorrhagic stroke. Hypertension could be precipitating factor, rarely but not prominent as in adults. Risk factor for hemorrhagic stroke. Intracranial vascular anomaly, there's a 48%. There is AV malformation, cavernous malformation, and aneurysm. Hematological abnormality, 10 to 30%. Thrombocytopenia, hemophilia, von Willebrand disease, coagulopathy, secondary to the hepatic dysfunction, vitamin K deficiency, iatrogenic due to heparin and warfarin therapy, brain tumor 9%, and idiopathic 19%. These are the precipitating factor for this hemorrhagic stroke. Clinical presentation of hemorrhagic stroke. In intraparenchymal hemorrhage, there is a seizures, vomiting, rarely developing focal neurological deficit, altered sensorium, rapid drop in consciousness state from the normal even to the comatose state, and signs of raised intracranial pressure. In subarachnoid hemorrhage, there is a sudden catastrophic event that may be preceded by sentinel headache and severe first lifetime worst headache followed by sudden onset of vomiting and altered sensorium. These are the clinical features in subarachnoid hemorrhage. How to diagnose this stroke? A strong indication of suspicion is required to make diagnosis of hemorrhagic stroke clinically. Spontaneous bleed in the absence of coagulopathy in a setting of AV malformation is a challenging to diagnose at the time of first assessment. In an acute setting, CT brain is often investigation done first, and we detect the bleed in majority of children, but etiology yield is low. CT scan of brain shows hyperdensity in a left intraparenchymal region suggestive of hemorrhagic stroke. Although conventionally, many think MRI brain detection rate to pick up bleed is poor as compared to CT brain. The role of susceptibility where imaging sequence MRI brain has changed to the dynamic and promising option for the diagnosis of hemorrhagic stroke. CT brain with CT angiography along with MRI brain with this SW sequencing is often a neuroimaging of choice in a child with suspected hemorrhagic stroke. Digital subtraction angiography DSA is done in advanced center and its diagnostic yield is excellent. There is no clear-cut consensus regarding exact timing of this test in any standard guideline, and the decision is often clinical based on a feasibility. So what is the treatment? Immediate stabilization and supportive care mentioned in arterial ischemic stroke, administered vitamin K, fresh frozen plasma, recombinant clotting factor therapy, depending on the scenario, and neuroradiological intervention, surgical repair of AV malformation, and aneurysm. Today's talk key message: there is a considered stroke in any child presenting with acute onset of hemiparesis or a focal deficit, change in mental status, headache, seizures, and speech disturbance. MRI brain with MRA is an investigation of choice, but it is recommended at least the CT brain is performed within 1 hour of arrival at hospital in every child. ME venography is done if cerebral venous thrombosis is suspected. Aspirin has to be started in all cases of arterial ischemic stroke as soon as possible in absence of contraindication except arterial dissection, cardioembolic stroke, and hypercoagulous state. In CVST as well as AIS caused by arterial dissection, cardioembolic stroke and hypercoagulable strain, anticoagulative using low molecular weight dextran, there is a enoxaparin and unfractional heparin or oral warfarin is used. Thank you. Role of thrombolysis in pediatric age group is controversial. However, there is growing evidence and looks promising. Thank you.
Thank you, Dr. Bharat. It was an excellent presentation and quite a bit knowledge. I would like to open the session for question answers.
Thank you, Sharad. Thank you, Dr. Bharat. It's a very, very excellent presentation and very extensively you cover pediatrics and neonatal strokes. I just wanted to get some clarity on what is the difference between the silent stroke and the mini stroke. How do you differentiate one? And the second one, can stress cause stroke in children, or the anger also can cause the stroke?
Stress is not a precipitating factor in case of pediatric stroke. And if there's a pediatric stroke, I already talk about this stroke-like condition. So it is not a clinical characteristic feature like focal neurologic deficit with altered consciousness, with hemiparesis and mental disturbance.
Thank you very
So
much,
there's
Dr.
a stroke
Bharat.
is not a precipitating factor in pediatric stroke.
Can I ask the question?
Yes.
Well, thank you very much, Dr. Bharat. Really, it was a very elaborative and detailed lectures. And we were thinking that there is no stroke in the children and stroke is only in the older age. But a lot of information you have today's given to us. My one question is that, what is the possible percentage or prevalence of treatment of the interventional radiology in pediatric stroke, and what is the maximum time in getting the benefit from the interventional radiology?
If you intervene in pediatric stroke within 48 hours, 24 to 48 hours, outcome is good. And the most common etiology of this pediatric stroke, I'm working in this tribal belt, having so many prevalence of sickle cell anemia. So sickle cell anemia, severe iron deficiency anemia, and the cyanotic CSV, they are the most common cause of this pediatric stroke. So if you treat or intervention early, that's at 24 to 48 hours, the good outcome.
Thank you very much.
Anyone else has a question or comments?
Yeah, Saurabh, can I just follow up in the management of treatment in stroke in children? What is your experience about the prevention and treatment regarding the lemon water versus drinking water? How much it contribute in prevention?
Yes,
Dr. Bharat?
sometimes due to this rotavirus diarrhea is there and severe dehydration is result into stroke. So this the ORS is important for the preventions of this dehydration and also prevent the stroke.
There are some studies they're reflecting that lemon water can be preventable if you use properly, maybe 30% prevention.
Is a vitamin C. There is a it decrease this the cholesterol level. So when there is any hypercholesterol there in case of there is a familial hypercholesteremia, then it is useful, this vitamin C therapy.
And also in our neonatal nursery, we see a lot of birth asphyxia and HIE, hypoxic ischemic encephalopathy.
Right.
So we feel sometimes very difficult to differentiate between the stroke, whether it is a hypoxic or it is arterial, unless we do the proper investigation. Clinically, what is your advice?
If there is a hemorrhagic stroke, so two more common, I already told, there is a subarachnoid hemorrhage or there is an intraparenchymal hemorrhage. So by MRI, we can diagnose this condition and treat accordingly.
Dr. Bharat, is there any device that can give alarm before you get the stroke? Is there any digital type like diabetes, you get the rising sugar, hyperglycemia alarm come up, parents or family or children can be alerted, or weak, like symptom arrives sometime more than 24 hours, but it's gone unnoticed and children cannot explain and the parents sometimes don't recognize and get delayed. Is there any alarms type of system?
No, there is no some alarm time up. If there is a pulse oximetry and this can helpful when there is we can see what is the level of hypoxia and lead due to this hypoxic encephalopathy. No other alertness alarm for the diagnosis of this neonatal stroke.
Do you recommend cooling of the brain when they're having a stroke or seizure?
Cooling of brain?
Yeah.
No.
Okay.
Okay. Do we have more questions on the floor? Dr. Ravi, do you want to add any comments? Dr. Kazi?
Thank you, Sharab. This is Fazil Masih. It was. May I go ahead?
Yes, please go ahead.
Okay. Thank you, Dr. Bharat, for a very elaborate talk on a very difficult topic and a very common, and you tried to make it very simple. And we have learned a lot. And with the questions asked by Dr. Akhtar, I think things are more clearer. And thank you very much, Dr. Bharat. I think it was a very good talk and it was wonderful. Thank you very much.
Thank you for your kind words and appreciation for my talk.
Thank you, Dr. Kazi. He is the president for CMAAO. Dr. Naidu, do you want to add any comments?
Me, nothing from me, Saurabh.
So with this note, and I think we are dot on time, we would like to wind up this session for the day. And I sincerely thank Dr. Bharat to spend some time over here and give us detailed knowledge and presentation on a very important topic. So I thank you and I welcome him on this forum. With this note, I would like to close this session and thank you so much for joining in. See you again next week.
Thank you,
Thank
Dr.
you,
Bharat.
everybody.
Thank you,
Thank
Dr.
you very
Bharat.
much, Dr. Bharat, Dr. Naidu, Dr. Kazi. Thank you